Good afternoon. I'm Patty Johnson, coordinator of the Southeastern Council of Foundations Engagement Initiative. This afternoon, we're delighted to present our program, The Alzheimer's Epidemic, A Community Response to Care, presented by...
It's not a charge call at all. This is a webinar.
Excuse me?
Yes, I'm sorry.
Okay. We're delighted to present our program, The Alzheimer's Epidemic, A Community Response to Care, presented by Dr. Margaret Noel, founder and director emerita of MemoryCare and Tina Markanda, program officer at the Duke Endowment. Tina, I'm going to turn it over to you now.
Great. Thank you very much, Patty. And on Peggy's behalf and my behalf, we're very excited about the opportunity to be with colleagues this afternoon and to discuss this important issue, and specifically to focus on the MemoryCare model, which has had such a great impact in Western North Carolina and now is being replicated in other communities. To begin our session today, I wanted to just share a short biography on our main speaker, Dr. Peggy Noel. Peggy is the founder of MemoryCare, which is a nonprofit organization that is dedicated to the care of individuals with memory disorders and their families. The program was founded in 2000 and serves residents in Western North Carolina. This program has received numerous awards at both the state and national levels, including the prestigious Premier Cares Award in 2011. Peggy was also named the 2011 Geriatrician of the Year by the American Geriatric Society for her pioneering efforts to develop this MemoryCare model. She is also board certified in internal medicine and geriatrics, and she's also a fellow of the American College of Physicians. She also holds a faculty position with the UNC School of Medicine and also serves on the National Alzheimer's Association Board. Peggy is a compassionate, energetic, and caring physician and individual whose work has made such a difference for so many, and it's truly my honor for her to be a part of today's program. Patty, if we'll go to the next slide, please. Okay, great, thank you. And for this afternoon, we wanted to have a fairly short agenda, so we're planning to cover just a few topics. One, to share an overview of issues related to our society and the impact that memory disorders will have on individuals, families, as well as communities. And then Peggy will provide important information about medical and social issues regarding this devastating disorder. Next, Peggy will present information about the MemoryCare model, and then finally we'll close this afternoon with a question and answer session. Next slide, please. Great. To begin with, I wanted to share some background on the Duke Endowment. The endowment was established in 1924 by James Buchanan Duke, who was a successful businessman in the areas of tobacco and hydroelectric energy. He was also a true citizen of the Carolinas and wanted to give back to the communities that had given so much to him and his family. Next slide, please. He designed the endowment so that it would focus on 4 specific areas of work. These are all areas that had a profound effect on his life, and he wanted to support these areas so that they could also positively affect the lives of other Carolinians. These areas include child care, health care, higher education, and rural church. Next slide, please. There are a number of issues that are contributing to the increasing incidence of dementia in the United States. These include, first, the rapid growth of the 65 and older population. Dementia is primarily a disease of older adults, and given that the baby boomer population is just beginning to hit retirement age, this incidence will increase significantly in the future. In the Carolinas between 2000 and 2010, the older adult population increased almost 28%. In contrast, in the South as a region, this population increased almost 20%. And also of notable importance is that the fastest growing segment is those who are 85 and older. As a result, there will be more older adults, which means that there will be more individuals and more families that face issues regarding memory disorders. Next, it has been documented that the risk of dementia increases with advancing age. Almost 1/3 of older adults will develop dementia. And then finally, the role of the caregiver will be increasingly important. Often the caregiver is a family member who supports the patient by providing assistance for all aspects of life: medical care, safety, financial support, nutrition, socialization, and so many other areas. Caregiving is all-consuming, and as the disease progresses, it requires greater coordination of care and support of the loved one. Next slide, please. Dementia has significant implications for so many. First, for the patient, the continued and progressive deterioration of the brain will continue to have a more significant impact as the disease advances. Currently, there are more than 5 million individuals living with a diagnosis of dementia, and Alzheimer's disease is the 6th leading cause of death in the U.S. Next, for caregivers, patients and families live with dementia on average between 8 and 10 years after that initial diagnosis. The impact of the disease on the caregiver is equally profound. Not only must they endure the progressive nature of the illness on someone that they love, but the disease also takes a toll on the caregiver, affecting his or her health, physically as well as emotionally, and their well-being. More than 60% of Alzheimer's and dementia caregivers rate the emotional stress of caregiving as high or very high. 1/3 report symptoms of depression. Alzheimer's and dementia caregivers had $9.1 billion in additional health care costs of their own just in 2012.
Excuse me, Tina, we've got 2 people with their hands raised.
Okay.
Chris, did you have a comment?
I find people's questions a lot of times are good.
How about Jinx McCroy? Well, there may have been a mistake there. I'm sorry.
Right.
Go ahead.
That's fine, Patty. And then finally, this disease has a great impact on our society at large. According to the National Alzheimer's Association, in 2012, 15.4 million caregivers provided more than 17.5 billion hours in unpaid care, valued at $216 billion. And in 2013, Alzheimer's will cost this nation $203 billion. This number is expected to rise to $1.2 trillion by 2015. This disease is truly changing our nation. And for these reasons, programs such as MemoryCare are so essential. Peggy, I'll turn it over to you now.
Thank you, Tina. It's a pleasure to be able to share about our work and our appreciation for the philanthropy that has made it all possible. Before launching into the specifics about MemoryCare, I'd like to continue with some general information regarding how Alzheimer's disease and other types of dementia impact families. This will help set the stage for why a program like ours has filled an important need in our community. Western North Carolina is ahead of the curve with almost 20% of our population over 65. We consider ourselves an incubator for approaches to age-related issues that the rest of the country will wrestle with in the coming 20 years. As a geriatrician, I've spent my career caring for older adults, primarily older adults who have Alzheimer's disease and other types of dementia. Among all age-related diseases, dementia is unique in its impact on families due to the absolute dependency it eventually creates, the extended duration of the illness, and the dramatic changes it can have on the functional abilities, personality, and behaviors of the affected person. Intensive caregiving is the most important element of best practice care. Our model of care is designed to enable caregivers to assist a loved one to manage their disease, maintain dignity, and remain safely within a preferred environment for as long as possible. The program's unique approach integrates the care of the person who has dementia with that of his or her caregivers. Tina has already set the stage for...
Excuse me. I hate to interrupt, but we seem to have 2 questions again.
You're really going to do this?
Patty, can we just perhaps make an announcement that we will address them in the end?
Okay. All right. Thank you.
Okay. I never thought about that.
Dementia's been present through the centuries, and the interest now is largely due, as Tina shared, to the awareness that age is the #1 risk factor. Ironically, as we age more successfully in terms of having a longer lifespan, we increase our risk of developing dementia. By 2030, it's predicted that there will be more than 8 million people who are affected with dementia and 24 million caregivers. And by 2050, that could be as many as 14 million dementia cases and 42 million dementia caregivers. So currently there are over 5 million people in this country with dementia and a large number of people who have mild cognitive impairment that has a high likelihood of progressing to Alzheimer's disease or other types of dementia. As Tina mentioned, 1 in 3 seniors will die with dementia after an average course of 8 years. The direct medical costs due to dementia were estimated at $109 billion, rising to the $259 billion. And the additional indirect cost, which value informal caregiving, range from $159 to $215 billion per year. Direct medical costs now exceed that of cancer or heart disease, and recent public opinion polls show that Alzheimer's disease is now more dreaded than cancer. And this is a reflection of the lack of progress in identifying a cure or at least a treatment that delays onset. Alzheimer's is the only cause of death in the top 10 in America without a way to prevent, cure, or even slow its progression. And that sad fact relates to the lack of NIH funding directed toward dementia. Only $500 million annually per year, compared to 8 times that for heart disease or 12 times that for cancer, conditions where great progress has been made. Alzheimer's and other dementias place enormous burdens on families. Nationwide, 60 to 70% of persons diagnosed with dementia are cared for in their home setting. Over half of caregivers are employed, but their caregiving responsibilities have a significant impact on their job performance. Caregivers have higher rates of depression, poorer health, and greater financial distress. Dementia is an umbrella term we use for a syndrome that involves permanent changes in our brain's function, affecting our ability to think, express ourselves, learn, and remember. These changes are serious enough to affect activities of daily living and to require the assistance of another person to remain safe. Dementia is complicated. Findings from the best research centers show that dementia is predominantly mixed, and people with dementia often do have more than one type of pathology in the brain. In reality, the diagram at the right better represents what we see clinically. There's often overlap of the different types, the most common being Alzheimer's disease, followed by Lewy body dementia, vascular dementia, and frontotemporal dementia. Each of these types have both unique and common symptoms. I wanted to put the 10 warning signs before the webinar participants because they make it easy to see how dementia takes hold of our thinking and reasoning abilities, memory, and ability to navigate this world independently. I'll be happy to answer any specific questions you may have about these warning signs at the end, but essentially dementia slowly robs our capabilities in ways that will demand we receive help from others just to accomplish the normal activities of living.
No, we have to do it. I'm going to close this door so you don't hear.
This is different than normal aging, which we say can be annoying but not disabling. And our patients are not the only ones thrown into a world of confusion. Imagine watching this take place in a loved one and trying to find your compass to help when the person's constantly changing as the dementia progresses. In 2009, a bipartisan congressional task force on dementia published a report listing major concerns in regard to our country's readiness to deal with this epidemic. Fewer than half of the people with Alzheimer's disease or other dementias have been officially diagnosed with the disease. These misdiagnoses impede the delivery of needed care and services. A diagnosis provides the opportunity for families to consider medical and non-medical treatments, as well as clinical trials, to better manage medical conditions that will be affected by the dementia, to address safety issues, and to do financial and legal planning. They also noticed that the Medicare fee-for-service system rewards providers for a high volume of in-office services. This reimbursement policy effectively discourages the between-visit care and time-intensive support that's most valuable to people with dementia and their family caregivers. And there are interventions that are proven to increase the quality of life for people with dementia, yet many of the most promising, including community-based psychosocial interventions and caregiver counseling programs, are not covered by Medicare fee-for-service payments. So even earlier than the Congressional Task Force, the medical literature had recognized the need for a different model of care to address dementia. The things that were really starting to be noted in our medical literature were that caregivers need to be the dominant focus of any effective dementia management strategy. And truly, diagnosis is delayed without their input to a patient's history. And certainly, without capable caregivers, most patients who would have to possibly live in institutional care. They also noted that it takes a multidisciplinary team to provide the best medical care for persons with dementia, and that care needs to be integrated with social and community-based resources. And of course, the reimbursement system would need to change to support the above. When this paper was published in 2006, MemoryCare had already been in operation for 6 years. Even though reimbursement systems had not changed, we'd found our way through philanthropic support to grow a program providing a holistic, multidisciplinary approach that embraced the most important aspects of effective dementia care. Founded in Asheville in the year 2000, our mission was crafted to address unmet needs in our community, a program that considers the education and support of our caregivers to be as important as the medical care we give to our patients. The birth of MemoryCare was possible due to a grant from the Duke Endowment that was facilitated through the Givens Estates United Methodist Retirement Community, who graciously offered free space on their campus for our independent nonprofit charitable organization. The trustees' decision to provide the support could only be described as a risky venture, but they chose to invest in the idea that there had to be a better, more humane way to care for patients and families affected by Alzheimer's disease and other types of dementia. Our initial staffing was 1 physician and 1 nurse care manager, and we were able to show that we could sustain our team with a combination of insurance reimbursement, cost-sharing fees from caregivers, and community-based charitable support when the grant funding cycle was complete. In 2003, an extension grant allowed MemoryCare to expand to meet a growing demand for services with an additional physician and social work care manager. This doubled our capacity to provide comprehensive services and alleviated the long waiting list for enrollment. We were again able to raise our level of community support to sustain the growth, and other foundation funders, including Kate Reynolds and the Fullerton Foundation, followed to help us with another expansion and establish our first rural satellite in Yancey County in 2006. In 2007, a grant from the Duke Endowment allowed our program to establish an in-home assessment and support component for patients who cannot easily travel to the office setting, and increased our capacity to serve more families. This funding also allowed us to develop our Caregiver College, which is a comprehensive curriculum for family caregivers to gain the tools they need to care for a loved one with dementia in the home setting. A follow-up grant from the Fullerton Foundation assisted us to develop a web-based version of our Caregiver College for healthcare professionals. The need for services has continued to grow, and we're currently 1 year into our 4th expansion with the addition of a geriatric psychiatrist and a social worker team who established our 2nd rural satellite in Haywood County. A Duke Endowment grant partnered with funding from our local Biltmore company made this possible, and our Mission Health system has provided repeated grant funding through their community benefit program that has had significant impact on sustaining our expanded operations. Our first grant gave MemoryCare the opportunity to show that we could find community support to sustain operations. In addition to individual donors, each of these foundations have contributed in a major way to help this program take root and prosper. Whether it was for a special project or for recurring operational support, all have made a tremendous contribution to this nonprofit's ability to successfully carry out its mission. Let me tell you about what we accomplished with these investments, but first, where would you find us? Our main office is located in South Asheville in space made affordable by the generosity of the Givens Estates community. Our satellites are located in Burnsville, and it's actually in space that's contributed by Yancey County Hospice. And then in Waynesville, here we go. And this is in space that's contributed by the Haywood County Senior Resource Center. The Asheville and Waynesville locations have caregiver resource centers for the general public's use on site. And this is the beautiful old manor house, and this is our Asheville office, and it itself is therapeutic and inviting to patients and families who need our services. When a family chooses to enroll in our program, they pay an annual caregiver cost-sharing fee of $495, which is waived for financial need for about a third of the families we serve. And our multidisciplinary team provides the following services: accurate diagnosis and disease planning. This is extensive and includes detailed information on prognosis, respite and in-home care options, long-term care planning, and prompting to address necessary financial and legal issues, as well as safety issues that are unique to dementia. As I mentioned, as many as half, if not more, of people meeting formal diagnostic criteria for dementia remain undiagnosed. Behavioral management. Caregivers will tell you that dealing with personality and behavioral changes is the most stressful part of their role as a caregiver. And caregiver education, training, counseling, and support and coordination of services that are provided by other agencies is a very important part of our job. We've learned that this component can have tremendous impact on the lives of our patients and their caregivers, and the needs constantly evolve as dementia progresses through the different stages. This is provided one-on-one in Caregiver College and through our Caregiver Network. We review all medications and prescribe for dementia-related needs. It's our goal that 100% of our families receive direction for addressing advanced directives and defining wishes for end-of-life care. An extensive written care plan is provided to each family, as well as the patient's primary care physician. This document seeks to give all professional and family caregivers accurate and complete information on medical history, areas that need addressed, and recommendations for how to do so. As you can imagine, our patients are frequently not able to give reliable and accurate history, which can lead to medical errors if information is perpetuated in the electronic health record. Our home visitation program is limited to Buncombe County due to cost, but it does allow us to make visits in a timely manner when problems arise for patients who cannot easily come to our office due to physical or behavioral issues. We have a wonderful lending library of caregiver resource materials and technological aids in Buncombe and Haywood counties, and it's open, as I said, to the general public. And we provide education on aging issues to the community and training to other healthcare professionals in geriatrics. In 2012, over 3,400 individuals, including students, professional healthcare providers, community members, all received dementia-related education. MemoryCare offers our Caregiver College a 12-hour dementia caregiver training course to the public 3 times a year. As mentioned, we maintain the 2 lending libraries, an educational website, and community support group network for caregivers. And we offer a fee-for-service care manager resource services for families who may not want to enroll in our program but need a specific or have a specific need for help. In 2012, we provided comprehensive care for 980 patients and 2,927 caregivers. For every patient we see, we have 3 caregivers enrolled in our program. Our patients ranged in age from 51 to 103, with a mean age of 78. 2/3 were female. This primarily reflects the greater longevity of women, but there is also a slightly higher incidence of dementia in women. 96% are Caucasian, 88% of Buncombe County is Caucasian, so the statistic there is a little bit skewed. It's truly a regional program with 55% from Buncombe County. The remainder come from 23 other counties in predominantly western part of our state. 53% are low income by federal poverty standards. We classify the primary caregiver's relationship to the patient. 45% are a spouse, 50% adult children. And as you can see, the greatest proportion of patients are still living in the home setting, 88%. 9% of our patients live in assisted living facilities and 3% in skilled nursing facilities. The average length of enrollment in our program is 3 years with a range of 1 to 11 years. One of the measures of functional dependency, as well as a criteria for being eligible for nursing home care, is a person's need for help from others in their basic activities of daily living, or ADLs. This includes bathing, dressing, continence, toileting, feeding yourself, and walking. If you're low income and you need help in 2 or more of these areas, Medicaid considers you eligible for nursing home care assistance. 44% of our patients would be considered functionally dependent to a level of qualifying for nursing home care. We also track our patients' cognitive performance by a number of tests, but one that's often used in research studies is the mini mental status exam. A perfect score on this screening tool would be 30. People transition from mild to moderate stage of dementia around a score of 20 and will require help with managing finances, medications, nutrition, driving, and generally cannot live alone at this point. We have patients ranging from the mildest impairment to the most severe. This is a summary slide just regarding our growth trajectory, and it gives the timeline regarding the components we added. I want to emphasize that each of these components are only possible due to grant support to start them, and we've been able to find ways to sustain each one. Because we received grant funding from our very first year of operation, we began to measure what we felt our most important outcomes would be. Clearly, our program is about helping a caregiver help a loved one with dementia to have the best quality of life possible. We do a yearly caregiver satisfaction survey with randomly sampled primary caregivers, and I've included the last 3 years of results. Our response rate for this mail-out survey in 2013 was 50%. For those caregivers whose loved ones were still living in the home setting, 83 to 90% of respondents over these 3 years felt that MemoryCare was helping them to be able to keep their loved one at home. 94% of respondents noted they were better able to manage dementia-related behaviors due to MemoryCare's program. While caregivers often respond that nothing can take away the stress of their role from their shoulders, 79 to 84% of respondents over this 3-year period stated that the program helped them to better manage their stress. And 96 to 97% consistently report that they've gained an increased knowledge about dementia through their participation in this program. This is purely observational, but relative to the percentage of people with dementia who live at home on a national basis, MemoryCare is a consistently increased home-based population in our care. Without a randomized controlled trial, it would be difficult to accurately assess our impact, but we do know caregivers perceive the program helps them keep their loved one at home longer, and that we have a higher percentage of patients at home. One could postulate that we've simply attracted motivated caregivers who want to do this job, but we have made conservative projections about cost savings to the Medicaid system. In 2012, 197 of our patients were nursing home eligible and low income, meaning they would use Medicaid funds if they were placed in facility care. If we just assume that we help half of those families delay nursing home placement by 1 month, we can postulate $541,000 in Medicaid savings. If even 10% of our eligible patients have nursing home placement delayed by a month, we would be saving $108,000 in Medicaid dollars. And these savings are contrasted to our total cost of services, which are $1,200 per family per year. Our annual operating budget is $1.2 million. As you can see, MemoryCare receives 24% of its revenue from fees generated through insurance for patient care and 17% from caregiver fees that are charged to the caregiver for their counseling, education, training, and support. 26% of our operational support comes from a combination of our annual fund and endowment income. We do 2 mail-out solicitations per year, and we conducted 1 5-year-long special campaign to raise a permanent operating fund. We do an occasional event, but they have been more in the category of fundraisers than significant fundraisers. 13% of our funding comes from recurring grants for operations, and 20% from grants that are limited to a fixed period or special projects. Here are our operating expenses. They're categorized. Our main expense is our staff who carry out the clinical and care management services. This budget covers 3.6 physician FTEs, 2 social work FTEs, 1 nurse FTE, and 3.4 support staff FTEs, and 1 development director. Our occupancy expenses are kept to a minimum by donated space and reduced rent space. Our per-family cost, as I said, has remained steadily at $1,200 per year for the entirety of our years of operation. Preparing this has been a wonderful opportunity to reflect on our perspective as a grantee on how philanthropic funding has shaped this organization. I don't know if foundations think of themselves as venture capitalists, but clearly they make calculated decisions to invest in startup nonprofits that may not be able to sustain themselves. MemoryCare, with its mission to serve all in need, regardless of ability to pay, with its focus on a population that was often marginalized within our healthcare system, and its location in a community that's already heavily saturated with nonprofits, is fairly considered a risky proposition when anyone looked at our business plan in the year 2000. If the Duke Endowment staff and trustees had not seen value in this service that would allow it to eventually balance the profit and loss statement in a way that might be outside of the box of traditional healthcare funding, we certainly would not be sharing today about our 13-year history of growth and the impact on our community. Foundations have enormous power to encourage innovation and visionary thinking, and what a difference it's made for MemoryCare and for the families we serve. When a caregiver brings a loved one to our clinic, we know from their investment of time, energy, and financial resources how much they value this person, and it compels us to want to assist that caregiver to do the job before them. When one foundation makes a significant investment in a nonprofit, especially in the startup phase, it communicates value to other foundations and community philanthropists, paving the way for more successful fundraising. In the beginning, some of the foundation requirements seemed overwhelming. I remember thinking about how many more families we could serve if we did not have to pay the cost of a certified audit or do regular impact surveys. One of our early funders insisted on these practices, and over again, they've made the path forward much easier for MemoryCare. For any nonprofit who relies on charitable support for half or more of their operating budget, a growing waiting list for services can be extremely daunting. You are torn between the demand for services and the realization that every family you see will require additional fundraising. Every time we would speak to the public about needing more support for our unique model of care, we receive a rush of phone calls from people who needed that unique model of care. I'm certain it's the same for many nonprofits. The fundraising model that has ultimately worked best for us has been to solicit grants each time we needed to grow to cover for a 3-year cycle of expanded operations. And during that 3-year period, we were able to raise the ceiling on our community support to sustain the expansion when the grant cycle was complete. When I started MemoryCare, one of our board members, who was extremely gifted at pulling community organizations together, stated, "Collaboration is an unnatural act." Foundations have the big picture view to forge community partnerships and the power to push nonprofits to find avenues of collaboration that will multiply scarce resources and avoid duplication. And we've certainly found that in our community. And finally, foundations have the ability to help other communities take promising programs to meet societal needs and replicate them. Components of MemoryCare's model have been replicated in the Greenville Health System under Dr. Hiep Pham, and more recently a replication is underway at Novant in Charlotte under Dr. Chuck Edwards. Programs like this will make greater sense financially if they're ever fully appreciated for their potential to save healthcare dollars through reducing hospitalizations and nursing home utilization in bundled payment systems, and I'm hoping Tina might speak to that. I certainly think we've achieved the triple aim of the Institute of Healthcare by improving patient and caregiver experience, improving their health through better management of a chronic condition, and doing so at a reduced cost. These are the faces of our families, mothers and sons, husbands and wives, fathers and daughters. They are the reason we do everything we can do. And they are the people that would also want to say thank you to the foundations who so generously supported this work. Thank you.
Great. Peggy, thank you so much for sharing such important information and the work that you and others at MemoryCare are doing within Western North Carolina and other communities. As we begin to close, we wanted to share some information about some issues that foundations may wish to consider as they are looking at community-based programs such as MemoryCare. First, the need for services to support patients and families facing dementia will only continue to increase. We're just on that front wave of this baby boomer generation that's starting to reach retirement age, and that silver tsunami is very fast approaching. Next, in addition, within communities, currently there are limited resources. There are few providers and very few community agencies that exist to support patients and families with these special needs. Next, from the endowment's perspective, our trustees believed that it was important to invest in best practices so that consistent and positive outcomes can be replicated. And in the case of MemoryCare, in both the Greenville and Charlotte communities, this program is being replicated. And then finally, it will continue to be important to support programs that have a dual focus, both on the patient as well as the caregiver going forward. So at this time, Patty, I think we can probably maybe take people off of mute and go into our question and answer session.
Yes, thank you both so very much. And we've had some hands raised. I think I lost Chris Cooper, but Barrett, you had a question.
Yeah, this is actually sort of along the lines of collaboration, and it's just informational. I know y'all are up in North Carolina, but I wondered if there was any relationship so far with MemoryCare and the Alzheimer's Disease Research Center here at Emory at this stage.
Not actually, our geriatric psychiatrist came from Emory, and but our main collaboration would be when patients want to enter into research trials. Then we match them up to trials, and Emory is a common location for that.
Okay. Yeah, I just wondered, since ADRC is the only Alzheimer's Disease Research Center in the Southeast, but they also do patient care. There is that element, and if there was some opportunity for synergies there. That's all.
Thanks.
Sure.
All right. Do we have any other questions? And don't forget to hit *7 to unmute if you are muted.
Peggy.
Mm-hmm.
This is Randy Brantley with the Novant Health Foundation in Charlotte. I'd like to ask Dr. Noel how she and her staff go about introducing the giving opportunity to family members and patients.
You know, Randy, that was probably the hardest hurdle for me as a physician. It's not something that we're trained to be comfortable doing, and we certainly would love that healthcare was completely covered. And if I hadn't been to a place of realizing that there's no other way to do this, I don't think I would have been empowered. But we don't do any direct asking at all within our clinical and caregiving interactions. But if you're in our building, it's really apparent, you know, that we have needs, and we have our philanthropic material out so people can see that. We make it clear that we exist because of philanthropic funding, and so when someone registers or enrolls with us, we explain our fee system and that it's not the entire, you know, we don't charge the entire $1,200 because we've been able to raise funds to keep it a more manageable fee. So we explain those things, and then in return, you know, the majority of our annual fund participants are people who've received the service, and to me that's kind of an outcome measure in and of itself. If it's a valuable service and there were no other mechanisms to support it, we found our community has really valued it with those charitable contributions.
That sounds like a good approach. Thank you.
Okay, we have time for another question or two. Well, I would say that Peggy and Tina, y'all have answered everybody's questions. Okay. Do you have any last comments to make?
Patty, I just welcome anyone who, you know, has questions or needs information to contact me. The information is on this slide, and welcome, you know, sharing. Certainly really appreciated the opportunity to engage with the Greenville and Charlotte programs, and it's exciting to see each community find their way to provide these services to the people who live there. So again, just welcome. And the other thing we did provide, I think you sent as an attachment handout to those who were registered, a process map that we did at the time of the Premier Cares Award, but it outlines how we started from the very beginning and the components of our program. And again, we've learned so much in these 13 years, and we're delighted to try to share that and help others who might like to do this work.
Okay, thank you very much. As one of those caregivers dealing with this, makes me wish I lived in Asheville. We thank you so much for your time and for sharing this information with us. And thank you for publishing how to get in touch with you and Tina so that people can do this. I thank you all for participating, for listening in on the program. If you would like to hear it again, it will be up on YouTube at the SECF channel, and I'll send all the registrants a link to that. It'll probably be sometime next week. Don't forget to fill out the survey as you leave. And before we leave, let me tell you about our next program. We will not have a webinar in July. Enjoy your vacation, everyone. But we will resume in August with a program called Aging with Dignity and Independence in the Community. It's hosted by the Patterson Foundation and presented by Dr. Kathy Black, Hartford Geriatric Social Work Faculty Scholar and Associate Professor at the College of Arts and Sciences, University of Florida at Sarasota, Manatee. Dr. Black will share a community-based initiative aimed at better understanding the positive aspects of aging with dignity and independence. So we hope you'll be with us on the third Wednesday of August 21st at 3 o'clock Eastern, 2 o'clock Central. Thank you so much for your time and attention. Bye-bye.
Thank you, Patty.
Thank you, Patty. Thanks, Tina.
Thank you, Peggy.
Thank you. Please stand by.